Welcome back to Get Lit, the Dermatology Digest Literature Lessons podcast with Dr. Ted Rosen, a professor of dermatology at Baylor College of Medicine in Houston, Texas, and the editor-in-chief of the Dermatology Digest.
Hello, this is Dr. Ted Rosen, editor-in-chief of the Dermatology Digest, bringing you another edition of Let's Get Lit. And I've got an action-packed agenda of stuff to go over from recent literature. So let's get right into it. In the March issue of Journal American Academy of Dermatology, there was an interesting article saying that antibiotic administration for acne, while it's not a substitute for traditional means of STD, sexually transmitted disease prevention, in fact, when they did a large-scale study using that TriNet X database that a lot of folks are using these days, they found that people who had doxycycline on board on a daily basis for acne actually had reduced risk of sexually transmitted disease by about 25%. Of course, the question becomes, if you keep giving people antibiotics like doxy, are we not going to potentially increase the risk of resistance? And that remains a question. In the February issue of Clinical, Cosmetic, and Investigative Dermatology, there was a Chinese study looking at who gets burning skin with rosacea. There are certain specific triggers they found, not terribly surprising: consumption of spicy foods and alcohol, frequent face washing, excessive use of cosmetics, participation in sports, probably because of sweating, taking hot baths. But the one I found most interesting that they disclosed in this Chinese study was that burning skin correlates with periods of bad mood, whatever that means. In the April issue of JAMA Dermatology, there was an interesting article on atopic dermatitis and academic performance. And based on results of compulsory examinations of 16-year-olds done both in England and in Denmark, there was no decrease in academic performance when you compared those with atopic dermatitis to those without atopic dermatitis. This despite the fact that we know atopic derm and its associated pruritus can interfere with sleep and interfere with concentration. In the February issue of Dermatology and Therapeutics, there was an interesting study looking at a large U.S. insurance database for atopics, and they found out that despite guideline recommendations against the systemic use of corticosteroids, nearly a third of patients now, contemporary, with atopic dermatitis are receiving between 1 and 3 months of systemic steroid therapy. For a whole variety of reasons, we hope that goes down. In the March issue of Journal of Dermatological Treatment, a study from Saudi Arabia looked at atopic patients and compared a wide variety of therapeutics, both physical modalities like narrowband UVB phototherapy and a variety of pharmaceutical interventions. And they found that the greatest SCORAD reductions in their cohort, this was a multi-center cohort of 1,000, the greatest SCORAD reductions were seen with dupilumab and upadacitinib. Those two stood out. Not terribly surprising. In the April issue of JAMA Dermatology, there was a Danish study which pointed out that individuals suffering from chronic lymphocytic leukemia, and they looked at a pretty large cohort, over 8,300 patients, have a greater risk over a 10-year time period of developing both basal and squamous cell carcinoma. So you have to watch out for those CLL patients. In the April issue of Cancer Research Communications, there was a really interesting article that in their large-scale study pointed out that individuals who have never been married develop cancer at significantly higher rates than those who have been or are married. And this difference holds true for a wide variety of neoplasms, including and especially melanoma. I think it's because a spouse or significant other bothers you about using your sunscreen or staying in the shade or wearing a hat, maybe. But at least for a wide variety of cancers, being married seems to be protective. I showed this study to my wife and she said, "See, I told you so." In the April 1, there was an FDA announcement that they approved orforglipron. It's called Foundeo is the brand name. That's a new non-peptide GLP-1 receptor agonist drug. It's a tablet taken once daily. It offers a different way of achieving weight loss, diabetes control, and then all the ancillary properties which we know may help cutaneous disease. It comes as 6 different dosages. You start at a low dose, and then you do monthly dose escalation until you have a therapeutic response and it's still tolerable. Now, this drug does not match the degree of weight loss typically seen when optimal dosing of injectable agents is used. However, it does give an alternative. After 1 year of the highest dosage, which is 17.2 milligrams per day, 50% of individuals will lose 10% or more of their body weight. That's a little under the kind of results you can get with drugs like semaglutide and tirzepatide. But there may be failures with those drugs, so this is another option. In the March issue of JAD Reviews, there were 22 published articles reviewed identifying factors leading to dermatology appointment no-shows. Who no-shows? Younger patients, patients with no insurance, and individuals with limited English proficiency. Not to discriminate against any of those groups, but that's where you might see some no-shows according to this study. In the April issue of Journal of Cutaneous Pathology, they illustrated very nicely the kratom-induced photo-accentuated slate gray, blue-gray dyspigmentation. Remember, kratom is abused. It can be smoked, it can be eaten, it can be put into liquids, and it's often taken to give people a high or accentuate the effects of other illicit drugs. But kratom is not illicit, it's available over the counter. The interesting thing about this article is it's one of the few articles that actually looked at the histology of kratom-induced pigmentation, and it consists of circular orange-brown granules that stain positively with Fontana-Masson stain, but negative for iron. So that's if you have someone with this pigmentation and they're kratom users. If you do a biopsy, there's now a way to tell on biopsy whether that's what's causing their hyperpigmentation. In the March issue of the JAMA Network Open Journal, there's a very interesting article that claims that about 40% of American physicians report having high moral distress. What's moral distress? It's caused by challenges in which the physicians are unable to act in a manner consonant with their own ethical issues. So, for example, if there's a metric that says you must do 30 biopsies per day, per week, per month, whatever, and they feel uncomfortable, they can't predict how many biopsies they're going to do, that may lead to moral distress. Moral distress is not the same as burnout, but moral distress can lead to burnout. 40%. That was very interesting. In the March issue of Journal of Drugs and Dermatology, there was an article talking about nationally representative cohort in emergency departments and their tabulation, their summary of how often wigs can induce trauma. Apparently, it's pretty common that putting the wig on can lead to lacerations and contusions, and or some ingredient in the wig can lead to both allergic and irritant contact, leading to patients going to the emergency room. Very rarely, eyes were also injured. Someone putting the hair prosthesis on and it hits the eye. So these are not totally without at least some risk. In the March issue of Dermatology and Therapeutics, there was a meta-analysis of 11 studies consisting of 600,000, that's a lot, patients with hidradenitis, disclosing an increased risk of cancer associated with hidradenitis, specifically an increased risk of head and neck, gastrointestinal, respiratory, and hematological malignancy, the latter category including Hodgkin and non-Hodgkin lymphoma. No increased risk in this study detected for skin cancer. However, we have always thought that hidradenitis, especially chronic, certainly carries with it a risk of squamous cell carcinoma in an area of chronic inflammation, but they did not detect this. There was an April news release I found a little amusing but serious. The world's top condom maker is said to raise prices sharply because of shipping disruptions in the Strait of Hormuz. And there's a concern in infectious disease circles that if condoms get too expensive, they won't be bought, they won't be used, and that there might be a surge in STDs following that. Unintended consequences of military action. Here's my favorite in this set of literature reviews. In the February issue of the JAD, there was a Chinese study suggesting the utility of saturated salt solution. The way you do that is you have water, you heat it up, you pour table salt in till it no longer will dissolve, then you take out the excess salt. So that's a supersaturated solution of table salt. And they use that for refractory warts. They studied plantar warts, but I think it probably would work for other verruca. And what they did is they soaked the feet daily for 30 minutes over 8 weeks. Daily, 30 minutes, 8 weeks with salt water. And at the end of that 8 weeks, wart clearance was 98.3%. That beats anything else I've ever seen. So maybe salt is the answer for refractory warts. I don't know. It's an interesting study. In the April issue of JAMA Network Open, there was a retrospective study done at 3 U.S. hospitals on syphilis patients identified as being infected with that disease between 2011 and 2025. And it turns out, for whatever reason, syphilis confers, at least in this study, a higher rate of cardiovascular related events, including stroke, myocardial infarction, peripheral arterial disease, aortic aneurysm, aortic dissection, and aortic valve regurgitation. Another reason not to get syphilis. And then in the April issue of Dermatology and Therapy, there was a group of skin of color patients with psoriasis who were successfully treated with guselkumab. That's not the point. The point was that the persistence of post-inflammatory dyschromia actually correlated more closely with DLQI than did the degree of psoriasis clearance. So even though you clear the psoriasis in skin of color patients, you should also consider follow-up if there's dyschromia. That can be either hyper or hypopigmentation, and you might have to treat that. My second favorite article was in the March issue of New England Journal of Medicine. This was a phase 3 trial of the TYK2 JAK1 inhibitor, not available yet, brepocitinib, but this was a phase 3 trial. And they tried several doses, 15 milligrams, 30 milligrams a day versus placebo for dermatomyositis. And you know, this is a hard disease to treat. And they found that the higher dose, 30 milligrams a day, conferred the following benefits: improved composite myositis increase, glucocorticoid tapering was easier, decreased functional disability, which of course is very important for the myositis aspect of dermatomyositis, and the important one for us, brepocitinib led to decreased skin disease manifestations of dermatomyositis. So it treated both the muscle disease, functional disability thereof, as well as the cutaneous manifestations. And I look forward to this drug being approved. By the way, while there hasn't been any literature on it, I know that brepocitinib, based on a news release, has also been studied for sarcoid with very good results. And lastly, I just want to point this out. There was an April 27th news release that based on a phase 3 study, the FDA has now approved this drug, anifrolumab, one we don't typically use because it's always been an IV drug for systemic lupus, but it's now approved in a self-administered subcutaneous auto-injector. And with that in mind, we probably should become more conversant with that drug and use it for lupus. Has it been used in skin-only lupus? Yes, it's been studied, and it works for that too. About 50% of patients respond quite well. So anifrolumab in an auto-injector, not an IV infusion, now available. So that concludes this edition of Let's Get Lit. I hope there were some interesting pearls and interesting concepts for you, and I'll see you next time.
Thank you for listening to the Dermatology Digest's Get Lit podcast. For more information on any of the studies referenced, visit thedermatologydigest.com.